So we will start. I'm sorry that the sound isn't working because I had several embedded videos, but Humber River Hospital did really develop based on a real digital vision and rethinking patient care experience using artificial intelligence. We are located in Toronto, Canada. You can see on the bottom of the screen the number of beds and the size of the area and the facility. And of course, this is a picture of it. What we are most happy about is that as a result of having been in the building a few years and the additional changes made, we've realized about a 20% cost benefit from innovation and business transformation, and we've reduced unnecessary harm to hospital patients by 30%. And I'll take you through a little bit of that and then talk where we're going. Our guiding principle was knowing that we had an opportunity to leverage technology to better all aspects of hospital operations, giving patients, care, clinicians and staff a much better experience. So 2 goals: improve cost and improve care, use our technology, use interoperability, and do something with it. We created a command center, and this is a picture of the command center. The Clinical Command Center is really a real-world predictive analytics solution, delivering value every day for patients and frontline caregivers. It has 33 LCD screens that collect data from the medical record or collect data from other systems in the hospital. 20 workstations. The staff in this area are not new staff. They are people that came together from other areas of the hospital. They help to solve the problems by being collectively together, having the data, having AI on the data to show them which areas to concentrate on, and then collectively they can help to solve problems in the organization. So the command center is really what we call the frontline bird's eye view of the entire hospital, and it really highlights accessibility information flow, a number of different things. It also provides an early warning system to detect potential health risks, alerts to flag real-time incidents, and eventually, actually starting this year, moving out to do the same thing in the community. The data is not only in the command center. It's not like central control. There are patient care areas who have same or similar screens. They use these screens and the real-time data for rounds, for shift report, for ad hoc problem solving, looking at discharge barriers, observation management, deterioration. And then the central, and they request help from the central command center if required. The central command center, bed prioritization, staffing, flow through the organization. How long has a patient been in emerge? What can they predict is needed in staffing in 2, 3, 5 days? And so they work back and forth. It's about using data, creating situational awareness, and getting that challenge of moving patients through a healthcare organization off your plate and having it work quite smoothly. We did this work with GE. There are others who do this, so it's not a commercial for GE, but there are many systems in our hospital where we, through interoperability, pull the data right from the existing source. It goes into the GE prediction and logic engine, where there is applications that then allow it to come up to the GE wall of analytics, showing the data that's important to show. In this many beds, and of course, where they use these throughout entire cities for hospitals, you cannot have everything show up. You've got to have a way of determining which data is important and which is not important. And you must, of course, have your team help develop the most important pieces that have come together for us, or where the staff have said, hey, I need you to look at this. So tiles really connect the dots between source data in real time, add smarts to it, so users can expedite, prioritize, and plan care. And there's many things we look at, and I will take you through some of those, but we know which patients are at a risk of infection, which patients are likely to code, when will we need to reroute an OR patient to recover in a different area because we don't want to hold the operating room up, which patients will need specialized post-care, and what are laboring moms at present a risk of any kind of an issue. So taking that data, what we do is we take the data in predictive systems, in prescriptive systems, or for anomaly detectors. So adding machine learning techniques and algorithms, you can maximize the accuracy and the robustness of what you have. And you will see here on this screen some of the things we are able to predict. So that's likely what will happen. And you can monitor whether in fact that's occurring. Prescriptive systems, what are the, who's going to be placed where based on how busy it is, surgical patient placements, etc. And then you can do anomaly detectors, which is really predicting where there's going to be a problem. Multi-generational plan, the command center. The first piece was patient flow and patient care logistics. And the reason for this, whether it's an acute care hospital or anywhere, is you spend less time managing the flow processes, less time doing capacity management, less time scheduling, and you can predict some staffing needs and be ready for that. These are the tiles that we have in the command center. 16 real-time analytic tiles that focus just on flow through the organization. Data from the patient record comes up into the system and lets us know where there are trouble areas. For example, in the emergency department, and we know immediately when a patient is admitted, we know when there is a delay in them being triaged, a delay in them being seen by a physician. Once they're seen, each process of their stay can be monitored, and with algorithms, we know whether or not that patient is having a delay of some sort. When they are admitted, we know they've been admitted. We know where the empty bed is. We know if the bed has been cleaned. So all of this is visual to us, and you can manage the flow through the organization. You can manage determining which physician groups have a higher patient caseload on a floor of acuity, and you can adjust your patterns. You know your discharge barriers, your delays in cares, many of these things. The biggest improvement our physicians will tell you occurred was that they are no longer waiting for their patients to have diagnostic imaging tests. We can pull all that data together and be able to resolve it. So really good on flow and processes. And if you could see this, Jane Casey, who's was our director of the command center, she's recently moved to Tampa, Florida, but Jane would show you and speak about the flow, the process, the benefits, and all of the data behind her that allows that to occur. But we will skip it because we're having sound troubles. Oh, you can't hear it, I don't think, so we'll move on.
Yeah, there is no sound.
Yeah, I know. I've got to end the show and move on to it and come back. Okay. So patient flow and patient care logistics, that entire thing, and this is how you pay for the rest of your work, actually improved our inpatient turnaround time for tests, reduced our allied health assessment days, and then the number of allied health we needed, the time a patient was in emerge, conservable bed days, all of those things that you waste staffing, waste time, have hallway medicine for, disappeared, and we actually saved the equivalent of 35 beds. Operational efficiencies up to 35 beds. So we, even during COVID, did not suffer anything around patients in areas where they should not be, nor did we have challenges with hallway medicine. So that was phase one. The multi-generational plan, phase two, was high reliability care. And this is clinical pathways and reducing never events. So we were able to take data from our, for example, vital signs monitor in the patient's room. The vital signs are taken. The nurse acknowledges that they're accurate for that patient, and they are automatically downloaded into that patient record. And once they are downloaded into the record, that is reviewed along with the lab work, the patient's mobility, their drugs, their diagnostic exams, and we know whether in fact we anticipate a challenge with that patient or whether their news score is changing. If it is, then the team in the command center becomes aware of that and they can connect with the staff. So there are several different early warning systems in the command center. The risk of harm tile looks at reduction of clinical care, infection, and other risks. Because this is really a very powerful one. It's built on a News2 program. It looks at sepsis during COVID. It looked at COVID and risk for respiratory deterioration. It looks at abnormal laboratory results not followed up on. Changing statuses of patients is what it looks at all the time. And that piece of it is very effective. We have a seniors tile. Most of us, that's what we care for, whether it's in the community or at home. This looks at length of stay reduction, improving discharge rate to home. It looks at medications that might cause dementia and resolves many of the delays in assessment and intervention that occur. We can determine if there are any drug interactions that may affect that patient. So lots of different capabilities in the seniors tile, which has been extremely valuable for us. We can even determine if a patient has not been out of bed in the last 24 hours if it is a patient that is to be up and mobile. And then a perinatal tile, which is probably my favorite, supports early mother-baby rescue and intervention, fetal heart monitor strips, the patient's results, their stages of labor all come together and really tell whether we have deterioration of the neonate, of the mom, and then after birth monitors the baby as well. So those have been very, very effective. John V. Solanke would take you through this. I know there is no sound, but I wanted to show you the screens that John V. would have shown. So you can see abnormal laboratory results, abnormal diagnostic imaging results. This is the clinical deterioration tile, and it focuses on bringing up only those patients for which there is a concern. The score you see there where it says score 3 or score 5 is showing if the patient increases in their condition. For example, it goes up by 2, then we're able to work with the staff on the floor and figure out what they need in order to be able to get that problem to be resolved. Can we help them? And you won't see anything of John B, but I will show you the results that have occurred as a result of this. We instituted the this phase of the command center in 2017-18. You may or may not be aware that around the world there are patients who are harmed as a result of hospital care not related to their condition. Medication issue, unknown sepsis, a cardiac arrest that wasn't intervened, a fall, many of those things. In Canada, the Canadian Institute of Health Information pulls records and now analyzes the harm that has occurred as a percentage of patient discharges. Our command center went in between 17 and 18, and the blue line here reflects the percentage of harm for patients at Humber River Hospital, which is around 2.9, and this year 2.1%. And you will see our region, large community hospitals across Canada, and in Ontario, the rates are between 6.3 and 4.4%. So we've seen excellent results from this, and our team continues to come up with new ideas and tiles to monitor. So the final piece in my last few minutes is care transformation. And care transformation is really now taking this work, taking this technology, taking the AI that we've applied to information and move it out into the community. Large volumes of patients can be managed if you're not managing every patient, and if you're not trying to analyze the problems and the results for every patient, but you're able to focus through AI on those patients who you need to call, you need to reach, you need to contact because things have deteriorated. So it's care coordination centered on the patient at home. We're going to leverage the command center experience and concepts to coordinate care around the patient in the community, working with all of our partners, monitor patient cohorts, maximize opportunities to intervene earlier, adjusting the care plan as necessary, and reduce reliance on human health resources to support our patients. Global populations are emerging as informed consumers of healthcare. Not all of them are now, but they're striving to make decisions autonomously and with the support of provider teams, rather than relying on coming to the emerge and prescribed care pathways, which may not be aligned with their personal needs. And so this phase of the command center really helps us focus on personalized care and empowering patients with self-management, patients and their families. Peter Bach would be speaking at this time if we had his voice, if we had sound, but what I wanted to show you was just a little bit of, this is Zembo, one of the robots that we've been able to program and work with patients to allow the patient to have an opportunity to put information into the command, into the device and speak to them about what their needs are to show their results. And I will just end this one and give you an example of that, of what it looks like. And you won't necessarily be able to see it because this also was a video. But what happens here is that the patient is able to enter their data in. They're able, this is a diabetic patient that we're monitoring at home, able to show their health system, capture that, confirms that it is them. And then what she does is she wants to show her blood sugar for the day. So it's recorded in her record. It's recorded here. Were there a problem, we would know that and be able to reach out if proper action were not being taken, and she would be asked to show